Welcome to the EKG Guy if this is your first time. I'm glad you could join us this week. So this patient, we have a 49-year-old obese male with hypertension and untreated obstructive sleep apnea. He presents with this EKG, and what I want you to do first is go through it on your own. Try to address these things here on the right side, all right? And then when you're done, come here and try to make a final interpretation. And then when you're ready, you can restart the video and we'll go through this together. So hopefully you had a chance to go through the EKG on your own and gave it a shot. Now let's walk through this, okay? And as you can see, we have a 49-year-old obese male. Actually, the BMI was 47, okay, so quite high. Hypertensive, untreated obstructive sleep apnea, and comes in with this EKG. All right, and I'll tell you, compared to previous EKG, straight from the start, his previous one showed normal sinus rhythm. Okay, so now we have this, and as you can tell, this is certainly not normal sinus rhythm. So let's go through this step by step. Let's start with the regularity, okay? And the regularity we do first because it helps to dictate some of the things that follow, okay? So what we want to do here, and sometimes the best thing, is to look at some waves that stand out. And what I use are some of these rhythm strips. So you can use any one of these, okay? And you can use any interval, but it's most often easy to find these big R waves that come here, these positive deflections, okay? So we'll use lead 2. And you want to look from one R wave to the next, okay? So here's the next one, so forth, okay? And all these between each are called R to R intervals. So from one R wave to the next is an R to R interval, from this to this, okay? And you're going to look throughout. And if you notice this, all right, this is actually an irregular rhythm, okay, meaning that the interval between these R waves is not the same, okay? So it's an irregular rhythm. And then normally, if it's irregular, we like to figure out, is it irregularly irregular, or is there some regularity to it? In other words, is it regularly irregular, okay? Well, in this case, there is somewhat of a regularity to it in that there's two beats, okay, they come with one another, all right, but not completely, because if you look at here at the end, there's kind of one standing alone there. So we would call this an irregularly irregular rhythm, okay, overall, all right, and maybe there's some regularity to it, but in general it's irregular, and that's the main thing that we want to get away from that, okay? And why is that? Well, because it helps to give us some ways to find the rate, which is the next thing. So finding the rate with irregular or regular rhythms, you can use this method, okay? And if there's one method you want to learn or use to find the rate, either atrial or ventricular, use this one, okay? So know that from beginning to the end is 10 seconds, okay? And when we teach any EKGs here, we use the standard 12-lead EKG, so you can assume this is 10 seconds, all right? And 10 seconds times 6 is 60 seconds, which is 1 minute, all right? And that means if we count the complexes going across times 6, we can get the rate in beats per minute, all right? So what we can do here is either find the ventricular or atrial rate. The ventricular rate, you can use the QRS complexes or T waves. In this case, we'll use those QRS complexes. So let's do that here. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. So then you would do 18 times 6, and 18 times 6, if my math is right, is 108, all right? And so 108 beats per minute is what we got. Now the actual machine gave us 106. Okay, so that's one thing to note. The machine gave us 106, and we got 108. Let me just write that over. It's hard to write on this screen, but the machine gave us 106. Okay, so quite close. Now there's other ways to find the rate, but because this is an irregular rhythm, this is the main way that I want you to learn, okay? Now you can use this way for both irregular or regular rhythms, so use this moving forward if you want to just commit one to memory. Next we have the rhythm origin, okay, meaning that where in the heart is this rhythm originating from, okay? In other words, this is our heart here. we're asking ourselves, this would be the right atrium, right ventricle, and left ventricle. Is it arising from somewhere here in the atria, or the ventricle, or is it somewhere in this region here, the AV junction? Okay, so that's pretty much the main thing I'm asking myself in this. So let's go through this. Now notice that our QRS complexes, which are these ones here, these big ones that we've been talking about so far, they're not wide, okay? Meaning that if they were wide, we might expect that the rhythm is coming from somewhere in the ventricles, okay? Because they're slow cell-to-cell depolarization, which widens and slows the depolarization wave, okay? So in this case, we have narrow ones, so we can pretty much assume that it's coming from above the ventricles, so we'll cross that out. Okay, next we have to ask ourselves, is it coming from the atria or sinus node? Well, the sinus node is up here, okay, and remember with normal sinus rhythm, we should see one P wave for every QRS complexes. In this case, we have these waves that are occurring here, okay, that are not so much one for every QRS complex, meaning that there's not one P wave for every QRS complex, and there's not that 1-to-1 ratio. Okay, instead you have these waves here, okay, that are coming, and that there's more than one before each QRS complex. So this is likely not coming from the sinus node. Is it coming from the AV junction? Well, that's certainly possible, but we have an irregular rhythm. So if it's irregular, it's rare that something is coming from that junctional area, okay? And that kind of leaves us to something coming from somewhere in the atria, okay? And in fact, this rhythm is originating from the atria, okay? Next, we want to look at ventricular access. Okay, normal ventricular access in our adult patients is between -30 degrees and +110 degrees. Okay, at least that's what we use here at Mayo Clinic. So between this region here is considered normal. Up here would be left axis deviation, meaning in this region here, this would be a right axis deviation, and up here would be a superior right axis deviation, or a northwest axis. Okay, you may hear of this being north, this being west, so this region and that. Okay, not too many things hang out there, but you may see VTAC, so ventricular tachycardia. That's one of the features that you can see occurring there. In fact, there was a recent published article that showed that, which didn't seem too novel, but they reported it as novel anyways. That's beside the fact. So let's find the axis here. So a few things that I want you to note is that lead 1 sits here and AVF down here. Okay, so these are sometimes the easiest leads to use to find the axis. And what you want to do is look at 1 and AVF. And notice that 1 is all positive, very positive complexes, meaning that the axis is heading towards lead 1 in that lead, or the impulse. In AVF, here's AVF down here, there's a few QRS complexes. There's one here, one here, one here, and one here. Okay, it's hard to tell where that is. It's almost isoelectric, and you have those waves that are kind of going within that kind of obscure the complexes that are formed. So another lead to look at, that just to help clarify things, is lead 2. Lead 2 sits at +60 degrees, okay, in this region. And if you look at lead 2 has these big positive QRS complexes, okay? And if you look there, that means that it's heading towards this way, and that the axis lies between this region here. And we said anything in that region here is considered normal. Now the actual axis that the machine got was +2 degrees, which would be pretty much right in this region here. This would be about +2 degrees. So slightly past that 0 degrees. So we have a normal ventricular axis, and it was at +2 degrees by the machine. So hopefully that makes sense there. One easy way or trick you can use is by simply looking at leads 1 and 2, and if they're positive, then you know the axis is normal, as we saw here. So that's another way you can use. All right, so let's move on to atrial conduction. Well, in atrial conduction, this is an area where we're looking for atrial enlargement, okay? And remember, with atrial enlargement, you have to have sinus rhythm present. So when those criteria were developed, they were developed in patients that were in sinus rhythm. So because our patient is not in sinus rhythm, as we said, the rhythm's originating from somewhere in the atria, then in fact we cannot comment on atrial enlargement here. Okay. In fact, this patient did have atrial enlargement, left atrial enlargement, and that should make sense. We have an obese patient, hypertensive, untreated sleep apnea with this rhythm that we're seeing here. Okay, so AV conduction. So pretty much, if we just try to kind of show you what we're going through, we went through, this would be the P wave. Here's our QRS complex and T wave. We said that we can't really comment on the P wave because we have no clear P waves that are originating from the sinus node. When we look at AV conduction, okay, we're looking from here to here, that PR interval. Is there any delay? Are there any dropped beats? And so forth. Well, there's no delay, there's no PR interval because we can't spot out any P waves here per se, but there is some sort of dropped beats, okay, or variable conduction. We said this is an irregular rhythm, so what we can comment on and should here is that there's variable AV conduction, okay, meaning that we have sometimes these that are occurring twice in a row, but notice that there's a space here between them. Two complexes and then a space. Okay, so that's quite variable. That's not normal. You don't have them all occurring at equal intervals. All right, so hopefully that makes sense. Next, we want to look at the IV, or intraventricular conduction. So we're making our way down from the atria to the AV junction to now the ventricles. And in the ventricles, we said earlier that we have QRS complexes, okay, meaning from here to here, that have normal QRS intervals. Normal in adult patients, as we have here, is between 70 and 110 milliseconds. And in this patient, it was 88 milliseconds. So, which suggests that we have normal IV conduction, and we said it was 88 milliseconds. Okay. Next, let's move on to some of these waveforms. So with these waveforms, we're looking at, again, we've gone through some of the main things. Now we're kind of going in more detail of the waveforms. Specifically, we're going to look at the PR segment. So just to clarify what that is, here's our P wave, here's our QRS. The PR segment is from here to here. We said that there's no P wave, so we obviously can't make out any PR segment, but where we would look here, is there any elevation or depression of that? So we don't have a P wave here, so we can't comment on that. The next thing to look for here would be any Q waves, any abnormal Q waves. In other words, a big negative deflection that comes at the beginning of our QRS complex and precedes any R wave. Okay, remember this here is an S wave. A Q wave would be a first negative deflection preceding that R wave. Okay, in this case, there are no significant Q waves that I would mention here. So we will not mention anything there. And then we'll look at the ST segment. And it's very difficult to tell with this ST segment because you have all these waves that are kind of going and going and going, and kind of can obscure that and make it look like there may be some depression, such as in V3 here. Okay, but I would be very hesitant to comment on that, given that otherwise we don't see any significant changes. So I would not say that there's any significant ST changes, maybe some non-specific ones, okay, likely due to the underlying rhythm that we have here. Next, we have to look at the QTC interval, okay, and the QTC interval is from the beginning of our Q wave, so if you imagine here, or QRS complex, to the end of this is our T wave. So it includes our QRS complex and the T wave. In other words, the QT interval equals QRS complex plus ST segment plus T wave. Okay, so all of that, this is our ST segment. Okay, so that's what that is. The QTC corrects for heart rate, and we tend to use it because it's more clinically helpful. In this case, the QTC interval, so correcting for heart rate, was 401 milliseconds. So 401 milliseconds, which in male adults is normal. Okay, less than 440 tends to be okay. Now, not until it's around 500 milliseconds that does it start to shift our focus and, you know, thought process of what we're using, or at least up in that upper range. Okay, is there anything else that we're missing here? That's what our next step is. Well, there doesn't seem to be anything significant. And now I want to look at our wave progression. So these last two things in the precordial leads. Okay, so not anything significant here that we could comment on per se. Maybe some weak inferior forces here. Okay, but otherwise nothing significant. So what we want to look for here is in the precordial leads the R wave progression. In other words, we want this initial R wave that I'm circling here from V1 all the way up until V5 to increase in amplitude. Okay, or you want the R to S ratio to increase, meaning the R wave above to the S wave to increase. Okay, and you can see that certainly doing so where the S wave is almost like disappearing in these last leads there of V4 and V5. Now there is a big jump from V1 and V2 all the way up to V5. So notice, or to V3. Notice how we go from kind of from here and then a big jump. Okay. So because you have that big jump, I would be hesitant to call this normal per se, okay? But it's hard because you have these complexes that almost look a little different here, okay? And look at the amplitude in each one. So I would almost question this, you know, and again, we could say normal, but I would question if there's abnormal. Now, the reason I'm not going to be so definite on this is because these last two things, these precordial leads, these are the leads that are placed on the chest. And it really depends on how they're placed, and there's no perfect science to it, so it's hard to really rely on that. And that, you know, when you see that big increase from V2 to V3, that may question that you have maybe poor anterior forces or septal forces here in V1 and V2. So that's just something to keep in mind. But otherwise, it's hard to really tell. But that's just kind of the thought process behind that. Now, in terms of transitional zone, this is our last point that we'll look at. The transitional zone, again, here in our precordial leads. Okay, the precordial leads are the ones V1 to V6. Again, we put on as the chest leads. And in this transitional zone, we're seeing where it goes from mostly negative to mostly positive. So it's negative, and then it becomes mostly positive here. You can kind of see that, okay? And then certainly by V4. So it's probably mostly positive around V3, okay? So between V2 and V3. And because it's between V2 and V3, we call that an early transition, okay? An early transition or a counterclockwise rotation. And because of that early transition, just like R wave progression, again, all lead placement dependent, but that early transition may suggest that there may be some infarct there or something going on in that region there on the septal portion. So an early transition there, but I would be hesitant to say that there's much more going on in that region without that, okay? And even potentially repeating that region may be helpful if clinically relevant, but I don't think it would be indicated. So anyways, that's that. So we have an irregular rhythm, a rate at 108 beats per minute. We have a rhythm that's originating from the atria, normal ventricular axis. Can't say much on atrial conduction. We said AV conduction is variable, okay? And remember, that's an important thing. So we have these waves here, okay? And just to kind of complete this, IV conduction was normal. Nothing so much on the waveforms from here, okay? And then we said that you know, we looked at nothing significant in the precordial leads that we would comment on. Maybe some non-specific ST changes, okay, in the ST segment. So let's kind of give ourselves a final interpretation and then talk for a minute about this. So this is actually atrial flutter, okay, and we call it with variable AV block, okay? So it's an atrial flutter with variable AV block. You could put non-specific ST T-wave abnormalities, okay, as we mentioned here, but I would be hesitant. I mean, it's a very vague code that we use, okay, so I mean, even the stuff we're using with artificial intelligence, quite hesitant to wonder what is it actually picking up. So anyways, the main thing that you want to take away is this atrial flutter with variable AV block. Okay, so let's just look at where we see these flutter waves. These flutter waves are these ones here. Okay, the best ones to find them are usually 2 and V1, but in fact V1 is very hard to see them. So if you look here, they're actually these ones here. Okay, and what happens is that you have these flutter waves that go like this, and they just continue through. So you can kind of almost trace the waves throughout, okay, if you just follow it. And they're even going through the QRS complex, okay? So in other words, if you were to look at just, you know, from here to here, you would say that this is a 1, 2, 3, 4 to 1 AV block, and then the one that follows it after from here to here, you have a 1, 2, and so about 2 to 1, or yeah, 2 to 1 AV block. Okay, and what does that mean? You have 4 flutter waves for 1 QRS complex, 2 flutter waves for 1 QRS complex. Okay, the one that follows 1, 2, 3, 4, because there's one buried in that QRS complex, it'd be 4 to 1. Okay, so you almost have this 4 to 1, 2 to 1 ratio going on. But overall, this is variable, and that's where we get that variable AV block from. Okay, so this 49-year-old obese male coming in with hypertension, untreated obstructive sleep apnea. This is a very important thing to be treated. Obstructive sleep apnea in patients overweight put them at risk not only for hypertension but also atrial enlargement, and that is an excellent substrate for atrial flutter and atrial fibrillation. Okay, and that's exactly what we see here. Atrial flutter with variable AV block, when compared to his prior EKG, showed normal sinus rhythm. Well, that's the end of this week's EKG of the week. I hope you learned something. Now I want to make you aware of our EKG coding reference that many of you are already using. How to get access, okay? So you want to go to this link here. So put in that link into into the computer, into your internet source, and then go to put your email address here when you get to that, and then you're going to use my password here to put in there. Make sure you're using my password every time, okay? And let me just erase here. So this one here, all lowercase, put that in, and then click submit. Confirm your email. So check your email, get a confirmation, and you'll have access, okay? And access here will be this, and you'll start to see that we have examples, and I'm now adding videos into it. So this is an on-the-go reference, has everything you could possibly imagine we use as we're building the course for our fellows here at Mayo Clinic, and so forth. So I think it's quite handy. Our techs are using it. We're using it for coding here as well. So very helpful way to learn, to use as a reference, and so forth. Okay, and you'll see a lot of the things we discussed in this lecture there as well. All right, so a few things. If you thought this was helpful, if you did, yes or no, I would like to know how I can improve, what kind of topics you want. Please leave them below. Like this video if you find this helpful, and share with friends. If you want more practice, okay, obviously more practice is on our Facebook page, where there's almost 500,000 of you there, and thank you for your support. We have daily questions, trying to get back to you between our clinics and making sure we're staying in touch. So go there for practice. There's daily practice. I leave resources. You can find us on Twitter, search the EKG Guy, YouTube obviously, and Facebook. Okay, it's hard to keep up with all these things, so find us there, share with your friends if you find this helpful, and please leave a comment if there's any topic, or just kind words. We always appreciate it, and I hope you learned something today. Well, thank you for making us the largest, fastest growing EKG community in the world.